There we go. And as far as the session, if you have not yet registered, please just make sure that you register first with your email address, send that to the toll-free number listed here. And then from there, once you've registered, you just need to send the word attend, and then the code for today is listed. But you'll send that to the number as well, and you should get CME credit. But do make sure that you check your transcript every so often to make sure that you are receiving those credits. So as we begin, I don't have anybody online. We're recording the presentation. However, we're having some connectivity issues today. So it'll just be us here in the audience. If you can help me out, I did put a QR code on some of the tables here, and you can pass it around, but that is to help us get some feedback on this session today. So if you could, before you leave today, make sure that you scan that code and provide some information for our presenter. Also, we're going to be doing some group discussion, so please, if you can, help us out with that and be engaged in the session. So again, South Texas Regional Family Medicine Grand Rounds, we are partnered with the South Central AHEC, and our mission statement is there for you. As I mentioned previously, just make sure you do check your CME transcript every so often to make sure you're getting those credits if you are registering those. And for those who are members of the AAFP, you can also get CME credit through them as well. But if you have any questions, feel free to reach out to me or to the AAFP. And we also just want to mention that it is our goal to meet these nationally established physician core competencies that you see listed here. And we also just need to mention that Dr. Thomas has no financial relationships with ineligible companies to disclose. So we have her presenting here to us today on continuous glucose monitors, the basics. I'll let her introduce herself and give the presentation.
Hi, everyone. So I'm one of the clinical ambulatory care pharmacists here in the system. I work at the Texas Diabetes Institute Adult Endocrinology under a collaborative practice with those endocrinologists. And so continuous glucose monitors, or CGMs, are one of the things I deal with almost every day. So I'm happy to come and talk to y'all about how you can use it in your practice. I also work with the medication therapy management department. So for this, our goals are to be able to identify who are those patients that we can prescribe CGMs for, and we'll get the best use out of these CGMs. Also go through the different CGMs that are available, such as Dexcom and Freestyle Libre, and figure out which one may be best for our patient. And then we'll go over some general insurance coverage, focusing more on Medicare and Medicaid because the commercial insurance varies. And then lastly, the group discussion will be going through 2 different patient cases, one Freestyle Libre and one Dexcom that actually seen in clinic. All right, so starting with the basics, what are CGMs? And how many of y'all have actually used CGMs in your practice? Have any of y'all ever prescribed them? Yeah, and I know Dr. Basildua and Dr. Davidson have some patients in y'all's clinics and they help manage those. So today I want y'all to become more comfortable with these, because it used to be only endocrinologists could prescribe them. We are now is opening up the floor for family medicine providers, primary care, and other physicians to prescribe them. So what are CGMs? They are wearable devices that will measure the interstitial glucose. And they're worn for 10 to 14 days at a time. It correlates with the plasma glucose. We do see some delays between what the plasma glucose is reading and what the interstitial glucose is reading. It can be about a 10-15 minute delay. If the glucose is rapidly rising or rapidly falling, the CGM is probably going to be less accurate. There are different types of CGMs. What we're going to focus on are the integrated CGMs, which these are the FDA approved ones that have the technology for patients to utilize their phones with it. We have real-time CGMs, which is the way we're moving in the future. These are going to be our Dexcom G6 and our Freestyle Libre 3. And then our intermittent scanning CGM is our Freestyle Libre 2, or you may have seen the Freestyle Libre 14-day, which is being phased out. So potential benefits of our CGMs. In observational studies and randomized controlled trials, we've seen benefits in improving the A1C, benefits in improving hypoglycemia episodes, especially those that are occurring overnight. It gives us a way to identify those, even when the patient's not having symptoms that their blood sugars are dropping overnight. It can reduce the acute complications, such as the hypoglycemia, also DKA and hospitalizations related to diabetes. We can use these in pregnancy, which that can help lead to improvement in neonatal complications, such as large for the gestational age, neonatal hypoglycemia, and others. And then also we see improved patient satisfaction. At the TDI Endo Clinic, we've actually been doing a study for our CureLink patients, where we give them 3 Freestyle Libre 2 sensors over a 3-month period. So they wear it for 2 weeks and then they're off of it for 2 weeks. And what we've seen there, even with the intermittent use of it, we've seen a reduction of 0.12 in their A1C, which doesn't seem like a lot, but sometimes for our patients, that's enough to get them started. And also, the patients will describe it as like a little birdie on their shoulder, or their endocrinologist is watching them. So I had a baker that was in part of the study, and when she wore the CGM during the study for the 2 weeks, her blood sugars were beautiful, no medication changes. Then she would go back to pricking her finger because she didn't have that little birdie on her shoulder. Her blood sugars would go up more into 200s, 300s. Same medication regimen, same adherence. So it's kind of an interesting thing because it helps the patients correlate, like, oh, I had that pastry for breakfast, my blood sugar went to 300, versus if I had a salad. And patients seem to like it because it doesn't hurt as much as pricking their finger, and it's really easy when they're on the go. They just can pull up their cell phone or the reader to the place that it is and get their blood sugars. And in studies, they also see once the CGM has been stopped, that there is sometimes a partial reversal of that A1C benefit, just because, again, they don't have the little birdie on their shoulder. Some cons of CGMs that we see is technology, and we are not always great with technology, especially some of our older patients. And so we needed technology. So having a compatible phone makes it the easiest, but we do have readers. Also knowing how to put it on. Some are more complicated than others on the process of actually putting on the CGM. Also increased educational. So these aren't something that you can be like, all right, prescribe, go do your thing. They actually need a lot of education on it to get the full benefit of this this increased expensive technology. So at TDI, what we're trying to do is we're starting up a group of education led by our certified diabetes educators, and also we'll do individual training with me or one of our CDEs. As soon as the patient receives the CGM symptoms and they're comfortable with it, they're not scared of it, we're going to get the best reports we can get. Other problems, because we are in South Texas and it gets really hot in the summer and people are sweaty, the sensors can fall off. So sometimes the adhesiveness can not be great. And so one of the great things about the Dexcom and the Freestyle Libre, if the patient can make the effort to call their customer service, they will replace that sensor for free if it fell off too early. There's also products on Amazon that they can buy that will go over the patch. They can even do just like a little Band-Aid, like if you scrape your knee, they can put that over as well. And then with insurance, like everything, any high cost medicine, it can take some time for that prior authorization to go through, especially if they require going through a medical supply company. So we tell our patients it could be 4 to 6 weeks before you actually get the system. And then lastly, the technology in the clinic. So these are things that you have to log into a website to get the patient report. So you can actually see the graph, which you'll see on the tables and we'll talk about later, about how much more useful that can be. And It also requires a USB access if the patients aren't using the reader, so they don't have a compatible phone. And right now in University Health, there's not a great way to get that access. We're currently trying to get it for the Southeast Clinic for a project they're doing. But at TDI, we have one laptop for the entire clinic, which can be very frustrating if you know the ins and outs of the Wi-Fi situations here. And if we're having a busy day full of CGMs or pumps. So biggest question, you're probably going to start thinking of your patients, and as I go through these, you're probably going to have a patient, you're like, maybe I should prescribe them a CGM. So they got to be capable in using that technology. Type 1 or type 2 diabetes. They can be used in adolescents. So I have had a few kids that really enjoy this because they don't have that stigma of having to prick their finger during school day. They can just hold their phone up because most kids have phones now, and they can look at their blood sugar and decide what insulin dose to give or what their pump setting is. It can also be used in pregnancy. They should be on multiple daily injections or continuous insulin infusion pumps. These are all from the ADA, by the way. And then also they could be on bolus insulin, having episodes of hypoglycemia or hyperglycemia, and make sure that insurance covers it, because these, we'll talk about price in a bit, but these are not cheap things to get, and there's not a whole lot of coupons out there. So going right into the 3 different types we're going to talk about. First is the Freestyle Libre 2. So this is an intermittent scanning CGM. So what does that mean? That means that the patient has to scan it every 8 hours. So they have to hold their phone up or their reader up to the scanner at least every 8 hours. Otherwise, we're not going to get the nice graphs that you see there on the handouts, because the sensor only carries 8 hours of data. So if they don't scan it every 8 hours, then we lose the path. Like, so say they scan at 8 p.m. and they wake up at 8 a.m. We lose the data from 8 p.m. to 12 a.m. So that can, normally we can kind of infer what's going on, but sometimes we don't know what's going on. The Freestyle Libre systems all go on the back of their arm. I always had the patients touch their shoulder to put it on. Freestyle Libres tend to fall off a little bit more because it is on the place that they're rubbing their body up against things or it gets caught. The Freestyle Libre 2, if they're using their reader or their sensor and it's within 20 feet of the sensor, it will give them real-time alerts if their blood sugar is falling, if it's too high, if it's rising quickly. And then something that's really nice, so for our patients that can't see well, they have a text-to-speech option on the phone. So it will actually read them out their glucose and tell them if it's stable, if it's rising, if it's going lowering. For clinic sharing option, if you go to libreview.com, this is where you can, the clinic can create a profile for the clinic, and then it can link up to the patient's phone, or you can, when you hook up the USB to their reader, it can pull up their reports, so you get all these fancy reports like you see on the tables. We have one of our nurse managers who's in charge of it, because it does require an email, a password, and then also a 2-factor authenticator, which was a new thing that happened about 6 months ago, and it caused a little bit of issues for us because we have multiple people that can log into the LibreView, and this LibreView, you can get on it on any University Health computer, which is great. The Freestyle Libre 3 is the newest one from Freestyle Libre. It's smaller, so I didn't point it out, but you can see the white little disc. That's the Freestyle Libre 2. The Freestyle Libre 3 is on his arm. It's a little bit smaller and a little bit thinner. It does not come with a reader option, so it can only be used with the phone that is compatible. This is important because our Medicare patients cannot receive a Freestyle Libre 3 because Medicare requires a reader. Just like the Freestyle Libre 2, it's wearable for 14 days. It goes on the back of the arm. This one is a real-time CGM, so that means they don't actually have to scan this. They can just, as long as their phone is within 33 feet of the sensor, it will give them alerts. It will take all their data and collect all their data. So when you see those reports, it will be a nice clean graph. And the Freestyle Libre 3 is not associated with any insulin pumps yet. And then finally, our Dexcom G6. So this has a few more parts. So the Freestyle Libre 3 is just a sensor and then a reader for the Freestyle Libre 2. For the Dexcom G6, they have a sensor, a transmitter, and a reader that they have to learn how to do. The Dexcom is good for 10 days, and it's wearable on the abdomen. If they are an adolescent, they can also wear it on the upper buttocks. For 10 days, the sensors are good for 10 days. The transmitter is good for 3 months. And it's very easy for patients to throw away the transmitter. It's a little white thing that goes into the sensor that they have to change every 10 days. And I've had many patients throw it away on accident, and then having to call the company and get it replaced is not the easiest thing. Dexcom is also another real-time CGM, so that means, again, they don't have to scan it as long as their reader or their phone are within 20 feet of the sensor and transmitter. They're good. They are coming out with a Dexcom G7. They actually just got it FDA approved. It's supposed to be coming out earlier in the spring, and it's approved for a backup arm and put the sensor and transmitter all in one. And it's shown to have the best data so far of all the CGMs. Dexcom is actually integrated with the Omnipod 5 and the Tandem T-Slim X2 pumps. So that means it creates that closed loop system. And so as the blood sugars rise, the pump will increase the insulin. As the blood sugars lower, it will stop or hold the insulin, which is really nice. So if you're thinking like, okay, this patient may be a pump candidate, I would go with the Dexcom because it has that integrated technology, and it will make it a little bit easier because we'll talk about that reason when we talk about the insurance. Dexcom has a clinic sharing option. It's the clarity.dexcom.com/professional. This one has a professional versus a personal CGM, and so you want to make sure you're always getting onto the professional side. Otherwise, your login won't work. All right, so CGMs and medications. There are a few medications that do interact with our CGMs. So Freestyle Libre interacts with high doses of vitamin C. So it's always good to check, make sure that they aren't on more than 500 milligrams of vitamin C a day. Dexcom interacts with Tylenol. So as long as they're not doing over the 4,000 grams of Tylenol a day, we're good, which they shouldn't be doing that anyway. And then for Medtronic Guardian, this one is not available as a solo CGM. It's only available if they have the pumps. So that's why I'm not talking about it as much, but yes, they can also, those are the other options. So affordability, like I said earlier, these are expensive prices. So for the Freestyle Libre 2, it probably, in the Freestyle Libre 3, they're probably our most affordable options. They can get a monthly supply for $130 to $150. That's not that affordable for most of our patients here. I do have patients that are on CareLink that are able to pay it because they were in that grant I was talking about and they really saw a benefit in it. But this is not affordable, and the only manufacturer coupon out there is for one free sensor. They'd have no other assistance available right now. For Dexcom, to get their receiver is $380 to $400. So if you're gonna prescribe this for a patient that's gonna pay out of pocket, I would look at phone compatibility, make sure their phone is compatible, because they can get the transmitter and the sensor without getting the reader if they're paying out of pocket. One transmitter, so they're gonna pay $45 to $60 every 3 months for that. And then a sensor is anywhere from $55 to $65, which comes out to be like $160 to $200 a month. So really, if they're paying out of pocket, I would go with the Freestyle Libre 2 or the Freestyle Libre 3. But hopefully their insurance will cover it, because insurance coverage has improved since they came out. For commercial insurance, it varies. So for the University Health Community First, like what the employees have, they actually have taken away all restrictions except being a diabetic patient. So if you have any employees or dependents of employees that are wanting this, yes, ma'am.
Just wondering if that includes like pregnant patients or just patients with diabetes.
Yep. So they have pretty much taken all restrictions away. Any type of diabetes diagnosis, it will be covered. And if they get filled out one of our pharmacies, this is $0 copay. Some other insurances that I've dealt with, like Blue Cross Blue Shield, it's hit or miss depending on what plan they have. Some plans will cover it fully, other plans will cover 50% of the cost. And then we'll talk about Medicare Part D and Medicaid for our CareLink patients. If you have 20 of those, it is not covered right now. We're hoping to change that in the future with the few projects we have going on to convince them to cover it for select patients. So for Medicare, biggest thing in Medicare is that the system has to have a reader and the patient has to pick up the reader. And the reader is good for 3 years, and they can only get a reader every 3 years. So if you prescribe them the Freestyle Libre 2, and you're like, well, they're thinking about going to a pump, which we have had in clinic, and it's only been a year, you have to go through many, many hoops to get them that reader for the Dexcom, and they won't cover the Dexcom system without that reader. So really think hard about, like, is this patient a pump patient potentially in the future? If they go to endocrinology, then I would highly recommend the Dexcom because it's integrated into those pump systems. Meaning also with the reader, that means they can't get the Freestyle Libre 3 because it has no reader. So for Medicare, our options are the Freestyle Libre 2 and the Dexcom G6. They also have 5 requirements. So they have to have a diabetes diagnosis. They have to be injecting 3 or more insulin injections a day or on an insulin pump. They require frequent adjustment. So this used to mean that they had to be on a sliding scale or correction scale of insulin with like their mealtime, but that's kind of been changed a little bit. It just means like they've had frequent hypoglycemia, hyperglycemia, and there's changes almost at every visit they had. They've had a in-person visit within 6 months of prescribing the CGM, and they had in-person visits every 6 months. For Medicare, they just have the general Part B plan, and they don't have any extra like Advantage plans, or they don't have the supplemental insurance. The patient will be responsible for 20% of the cost. So again, these systems are not free for most patients, so please let them know. I've had that be a case that they were under the thing like, oh, my insurance is going to cover it, so that means they're going to cover it in full. And then they get a little angry when they're like, oh, I have to pay $50 a month for this. So just, again, it's not free for them. For Medicaid, specifically Texas Medicaid, type 1 diabetes or diabetes during pregnancy, it also covers type 2, the same 3 or more injections per day or on a pump, and then they must meet at least one of the following, which is the unexplained hypoglycemia events, large fluctuations in their daily preprandial blood glucose, and then they've had hospitalizations or for ketoacidosis or uncontrolled glucose. So kind of more now moving into the CGM reports and how to read these. Does everyone have access to the files? Or,
I printed them out, so.
yeah, let's see.
Can I ask a clarifying question? From EPA recommendations that point, it doesn't have to be bolus.
Yeah.
But insurance purposes, that have to be on board.
Yes, so the question was, ADA says they can just be on basal, or they recommend it for patients just being on basal. But insurance, they require them to be on at least 3 injections a day. So that is a difference. It may, like I said, they're improving and lessening the restrictions as we go through. But it makes, right now, that is the case. Hopefully they catch up soon. All right, so one of the things FDA and the ADA kind of said were all these reports from your Freestyle Libre and your Dexcom or any other CGM have to have an ambulatory glucose profile, or AGP. And in those AGPs, they have to have these certain criteria. So CGM active time has to be more than 70%. So that means they're scanning at least every 8 hours a day for Freestyle Libre 2. Or with the other Freestyle Libre 3 and Dexcom G6, their phone is near them or their reader's near them more than 70% of the time. Their GMI, so this is going to be their glucose management index or indicator. This is what their A1C would be around if they continue that same pattern for 2 weeks. So we want that less than 7. These are for, again, a general patient that that's not very elderly or doesn't have a lot of other comorbidities where they're glucose control. We're gonna target like an A1C of 7.5 or 8%. Glycemic variability. This is talking about, is the patient going on a roller coaster at Six Flags with their blood sugars? So are they going up and down and up and down? If so, that's going to be more than 36%. And so we really want this to start stabilizing their insulin a little bit more. Average blood sugar, that's kind of throughout the 24 hours of the day, what's their average blood sugar? So the TAR is time above range, and they break that down into hyperglycemia level 1 and level 2. You can see those, and then time in range, which is going to be if their blood sugar between 70 and 180. That is a standard set range on all the CGMs. So if you think like, oh, well, for my patients, I don't really want them going under 100, and like under 200 is good, especially for our elderly population. The time in range is probably going to be a little off. But again, we want that more than 70%, which should mean that their GMI is going to be less than that 7%. TBR is our time to low range. And so we have another levels, hypoglycemia 1 and then hypoglycemia 2, which is our more severe. So that means their blood sugar is under 53 milligrams per deciliter. And you can see those. Ideally, we love hypoglycemia 2 to be 0. And these are all found in the ADA guidelines for 2023. So this is what the AGP report looks like on the Freestyle Libre for Freestyle Libre 2 and Freestyle Libre 3. So when I see a patient, you can actually take a screenshot or snip, like use the snipping tool and snip this, like put this picture into your note. I find this a little bit more helpful is because you have that graph at the bottom. Because if you just look at the time and range, the little flag is what we call it, that doesn't really tell you when are they high or when are they low and all that information. So you can see here, this patient is high most of the time. Target range is at 30%, so we have a lot of work to do. But then you can also see that they have random low blood sugars throughout the day. So we'll kind of talk about this more in a little bit. You can see their glucose management indicator is 8.4. And they are going on a little bit of roller coaster because their glucose variability is 38.5%. And that's on the first page of the Freestyle Libre report. The second page of the Freestyle Libre report has this glucose pattern insights. So it's a little bit more in detail about what is that AGP telling us? Are there trends that they've identified? Are there computer identified? It's not perfect. So this is what the daily log looks like. So for Freestyle Libre, they do it where, so it's all of these are 2-week reports, and they do it where day 1 is the first day of the 14-day period, and then it will go down to day 14. So the furthest date is normally number 1. So we have a few things to look at here. So the blue is their glucose, so it's kind of nice. You can see exactly what's going on, because normally if they're pricking their finger, all you see is where you see the little white dots. So you see a blood sugar of 91, you see a blood sugar of 308, you see a blood sugar of 129, but you don't know what's really happening in between. A few other things here is that they can actually log in when they're giving their basal insulin and when they're giving their bolus insulin, which is really neat. So the dark green is going to be their basal. So this patient's on a very low dose of basal. He's only on 5 units. But I can see that he gave it at about 7:30 that morning. And then the next is the little apple, means that that's when he ate a meal. So he can log in how many carbs he did. He did not do that here. But when he logs it in, he can also put his bolus insulin, which is the white box. And here he put 45. This was an error on his part. He only gave himself 5 units at this point. But you can see all these things. So you can see, like, are they doing that before their graph starts going up? So are they taking it before their meal like they're supposed to? Or are they waiting till after their blood sugar goes up and then they're dropping? So these are all kind of cool things. And then remember how I was telling you about the gap? So this patient has a Freestyle Libre 2. So he has to scan it every 2 hours. So you can see that gap in time because he scanned it at about 11 a.m. and then he didn't scan it until almost 9 a.m. the next, or 9 p.m. that next evening. So we lost about 2 hours of glucose data for him. And then this is on one of the last few pages of the report. So this kind of gives you, again, the little, like, within the percentile range. But the one that's more helpful is this low glucose events. So this puts in together, like, when are they having low blood sugars? Is there a certain time a day? So the darker the red, the more low blood sugars they've had at that time. So you can see a lot of his low blood sugars are happening about 10 or 11 a.m. Or a little bit overnight, and then some in the evening, and you can also see how low. So on the scanner, he got as low as 40 or even under 40. The scanner, just like the glucose monitors, they don't go lower than 40 or 400. So those are the ones we're going to see. And now we move on to the Dexcom. So the Dexcom first page looks a lot like the Freestyle Libre first page, except this is not their AGP report. Their AGP report is actually on the very last page, but it's just because it's in a different format. But this is what theirs look like. So a little different than Freestyle Libre is that anything in the gray is good. They're in their target range, and it turns yellow or orange if it goes a little too high. And then you can see their flag of the time and range. So they're at 60%, so doing a little bit better than the other patient at getting into that targeted range, and their GMI is about 7.4. Let's see. All right. So this is one of the daily logs for Dexcom. So here, so are people with Dexcom having to scan their sensor every 8 hours? No. So it's not that they didn't scan their sensor every 8 hours. It was their reader or phone was not within the 20 feet of them for quite a bit of time. So that's why we have that. In the Dexcom report, it actually will tell you what alerts they got. So at this 2:45 alert, it told the patient that it was high. And then they also had a low alert about 11:54 or 12 a.m. So we talked about that gap. And this is the AGP report. So again, it just breaks it down a little bit further, kind of shows you the more of the trend and like the 75 and 25 percentile range there. All right, what questions do y'all have about the report before we kind of go into our patient discussions? Any questions? All right, then let's go to our patient discussion. So this is going to be for the Freestyle Libre report. So AJ is a 35-year-old male. He's a type 1 diabetic. And like a lot of patients that had type 1 diabetes for a while, he has gastroparesis. So he is not very consistent on his meal times. And even when he does eat, he sometimes doesn't eat as much as he thinks he's going to eat. His last A1C was 10.9. Last GFR is 48. His current insulin regimen is 4 units twice a day, and then he's on a Humalog sliding scale that you can see. So, given all this information, I want y'all to break up in like groups of 3, 4, and talk about this for, let's see, like the next 5, 10 minutes, and then we'll kind of talk about what y'all found in the report and what I found in the report and what you could do with the report and how you could change his medication regimen.
We're gonna share the.
Yeah.
Yeah.
Did you?
I really did too, that's what I was gonna do when I was here and stuff, but. I had a meeting system. And I did right. That's how. Dr. Palacio, I can email it to you right now, or if anybody wants me to email, I can email a copy as well. Yes. Yep, this is that patient, right? This is that patient. So the freestyle after, so this is. Yep, so this is. Yeah. This one right now. So for the same, there's like A1C. So his PIR is already right now, so 70. The 88 doesn't. I tell you these are yeah, because they don't actually give you those. Media, I would ask like made up for them, and then if you're not, for like elderly patients, for like or there's so nature. Yeah. For y'all, it's more about. So. Yeah, so television, I know. And they have a reader, so they have. Yeah, like, it's promotion, that's not. I think they're like, they have, they're at home, they're comfortable enough to Libre you and. Which is why I always encourage patients that they have a compatible phone to use their phone, because if they said, they tell me, I am having low blood sugar overnight, like it's non-stop. And I can be like, log into the great people and see. Right, into the phone that says. All right, guys, for this time, let's talk about it. So, I have a few questions here. What is the patient's CGM goal? Or is the patient at the CGM goal? So was this patient's time and range at goal? No. Was he having
Too many low blood sugars, too many high blood sugars, what do y'all think? Lots of highs. What pattern did y'all see? Like, did you see, like, was he giving his insulin before meals and his blood sugar was shooting up even when he gave his insulin? Were y'all seeing that he was giving his insulin after meals or after his blood sugar reaches 400 and then it's dropping, causing those lows? What did y'all see? Okay. What questions would you want to ask the patient?
I would ask him if he's logging everything.
Good. Yep. So you want to do that. I was telling one group what I normally do is get a 3-day diet recall with patients, because not every patient's going to log. I have some patients that are fantastic at logging their insulin, like exactly when they get it. They can tell me what they ate and all those kind of things. Other patients, that's a little too much for them. I still train them how to do it, just in case, like, especially if there's something weird, like it is Christmas time, so a lot of people ate holiday meals. So putting that in, so you know why it's 400 or 500 when they normally don't have that. What other questions would you want to ask? All right, what changes would you make to his insulin regimen? Anything?
So I have a question, I guess, too, because like it seems like he and North kind of different doses of Lavamere often. Like he doesn't actually support. There's sometimes he does 5 and then other days he does nothing. So I guess like how we determine.
Yep, so that would be a question you want to ask, right? Is what are you doing? Because it's not consistent with what we're actually prescribed.
Yeah.
And so that's kind of like I said, they say it's their little birdie on their shoulder, is we can tell that, especially when they actually log in what insulin doses they're giving themselves. Sometimes this patient personally gets confused and he doesn't log everything on time, and he probably gets confused too, along with what's basal versus bolus, like when he logs it in. And you can tell he doesn't always follow the sliding scale very well either, right? So these are all things. His case was more of a educational case. So looking at his ambulatory profile, so we did see he's having way too many highs. So good job on identifying that. His GMI is 8.4 for him. He's a young guy. We really want to try to get to that 7%. So the timing is one of the things that I saw for him. As you can see, he documents at least when his blood sugar's on the rise. So he's getting alerts, and that's when he actually gives his insulin. So that's a big education piece for him. That's something we've been working on for months, trying to see it. So for him and other patients, I'll actually print out this report and we'll sit down and talk about it and be like, what if you did your insulin here versus there? Like that hill might not be as high. The other things is hypoglycemia education. So when he treats a hypoglycemia, so it's in the red, right? Do you think he's actually following the rule of 15? Do you think he's over treating? Yeah, so one of his big education pieces was also how to treat a low blood sugar. And this is not the first time he's heard it. He will drink a San Antonio favorite, the Big Red, and the whole thing of it. And guess what? It goes high. But it's also a quick acting sugar, so it goes high, he gives himself insulin, so then he goes low again. And so educating him on, all right, you only need like a half a cup of that Big Red to bring your blood sugar up, and then following it up with 15 grams of the complex carbs like peanut butter crackers or toast with peanut butter. So that's one of the things you can also see with this patient. All right, so the next patient is the Dexcom patient. So the Dexcom that you have in front of you, if y'all take a few minutes to look at this, we won't take as long on here, and we'll just kind of talk about her. So this is CC. She's a 66-year-old female, type 1 diabetic again. A1C was actually pretty good, 7.4. GFR was 38. She's on Tresiba 7 units daily, and then she's on a carbohydrate ratio of 1 to 30, plus an insulin sensitivity of 1 to 108 with a blood glucose goal of 110. So it's she's pretty sensitive to the insulin, if you can't tell. And the sensitivity ratio, insulin sensitivity is kind of a weird one, but she has a calculator that helps her calculate that dose and round it. So same questions.
Can you clarify that a little bit? That does not mean the one unit affects her by 108 points.
No, so she, for every 108 points in her blood sugar above 110, she gets 1 unit. Yep, and so the carb ratio is for every 30 grams of carbs, she gives 1 unit. Yeah. No. So a little bit more, yeah. So she really doesn't give much insulin at all for meal times. So how many of y'all deal with insulin sensitivity ratios and carb ratios? Y'all ever use them ever? No, just a little bit. Yeah, so it's really hard for our patients to actually calculate these, and it takes a lot of education. This patient, we tested her multiple times and made sure she understands like what her carb ratio is and how to calculate the carbs and stuff. Generally, we end up doing a sliding scale for her patients that don't quite understand this. So for the sake of time, we'll just kind of dive right into her. So it's the same question. So looking at her CGM data, do y'all think she's close to goal, or like how's her time in range or GMI? What do y'all think? So what is her GMI right now?
7.4.
Yep, so for her, we're actually targeting about 7.5%, just because she's elderly and she's had a lot of hypoglycemias. So she's right there. Looking at her AGP report that you see on that final page, we can see she's having some lows, and then her time and target range is not quite at that 70 mark, which is probably okay for her because she is elderly and we're targeting a higher A1C. But we want to look into what those highs are doing and also what those lows are doing, because she also doesn't have hypoglycemia. She has hypoglycemia unawareness. So she has no symptoms when she's low, which is why she got started on CGM in the first place. One of the patterns for her was, again, the hypoglycemia education. So this is where we're really catching things. If you see here, she went up, and then she had low, she treated it, and then probably didn't eat anything, and then she dropped again. And then she treated it a little bit and dropped again. So she may be doing the 15 grams of the quick carbohydrates, so that half a glass of soda, glucose tablets, and such, but she's not following it up with a meal or a complex snack like those peanut butter and crackers. So education on that is really important. The other thing we see is she is also talking to her. What we found out is at bedtime, you see how that she was high. So it's giving them multiple alarms at this point. And so because she doesn't want the alarms interrupting her sleep, she had been self-treating, giving her Humalog at bedtime without food, causing lows, and then she would treat it. And so we go on this vicious roller coaster for these things. So these are all like little things we see that we wouldn't really see if they're just pricking their fingers at breakfast, lunch, and dinner, right? We're getting a lot more information. And one of the things, as these become more popular for y'all, we want to make sure you understand how to use them and you're getting the most benefit out of this expensive but great technology. And again, another day example where it was high and she gave herself a nice dose of Novolog at bedtime. So wrapping it up a little bit, so are CGMs changing the diabetes game? Absolutely. These are empowering the patient to really learn like how their diet is affecting their diabetes and blood sugar, and letting them know what's going on with it throughout the day. It gives us a full journey versus just the destination. So we're learning if they're going multiple loops around and then getting to that destination, if they took 50 back roads versus just taking the interstate. We're learning all that information. And also, again, is an educational tool that we can help them see what different foods, what exercise, what stress can do to them, and anger, irritability, all these things, you can see it. And I have a patient that just recently, she was stressed because her blood sugar was too high. And as soon as she got stressed, her blood sugar went up another 50 points. Like you saw immediately, she didn't eat anything. I was like, did you stress out? And she was like, yes. I was like, and that makes sense. And so putting these things all together, because there's so many factors that interact with their blood sugar, is really important. So what's needed? Understanding these CGMs. It takes a lot of practice. I would say I see when I'm at TDI, probably 50 to 70% of my patients are on some type of CGM. So I have a lot of practice with this. It took me a while to completely understand the CGM report. So if you're just starting, please just keep looking at them. You'll see different things. I have my information here too that y'all can reach me at if you ever have any questions. Aurelia Bazadua and Dwayne Davidson are your pharmacists here in clinic, and they have experience too, so they're always a resources. Making sure their insurance is covering these. So one of the worst things you can do is, we're going to give you this great technology, and then insurance doesn't cover it, or they can't afford it. And it's just a discouraging thing for the patients. Also having CGM education. So either getting your pharmacist to do it or your diabetes educators. Please do not count on their outpatient pharmacy to do the education. Our outpatient pharmacists really don't know how to set these up properly, especially if you're trying to connect them to clinic. And then finally, getting all the technology pieces together. All right. So again, CGMs can improve those diabetes outcomes. We've seen it time and time again, even in our own little study. Most insurance have some type of coverage for our CGMs, as long as they meet the criteria, which varies from insurance to insurance. And then that AGP can really help you evaluate their blood glucose control and their trims. All right, that's all I have for you. Any questions, comments, anything? Yes.
On the previous slide, it looked like for some insurance to cover it, they need to maintain compliance with the reader and sensor for more than 70% of the time.
So, they don't require them to do at least 70% of the time. They require them to have those every 6 month in-person visits, and some require them to have CGM education within 30 days of receiving it. Medicare actually got rid of that rule of the 30 days of education, but some of the commercials do. You and your note. So they will so most of the time what they do, our endocrinologists actually have a smart phrase in Epic that they'll just put in there. That patient will have 30 days of education, like within 30 days they meet XYZ criteria. And so that just has made it a lot easier for our physicians when we prescribe it, and our MAs that are pulling the notes to be like, nope, look right here in the notes, is documented what they were. About a year and a half ago, Medicare was requiring them to test at least 4 times a day and have that documentation of testing 4 times a day. Thank goodness they scrapped that, because that made it really hard to get these. But great question. What other questions? Yes, sir.
Also, I have a 0% success rate prescribing these most often because I get a message back saying it's not covering. Is there like a cheat sheet the pharmacy uses to know which coverage options are out there?
That's a great question. The pharmacy won't know until they run it. And sometimes the thing is putting it into is whether it has to be through like a pharmacy or a diabetes supply company. with most of our Medicare Part D and our Medicaid, they have to go through the medical supply company, and not all medical supply companies are equal. I do have one of our MAs is designated to doing CGM supplies and getting it built. I will see if she has a resource and send it to Nicole to share with you. I believe she has one. I just couldn't get my hands on it just recently. What other questions do y'all have? Are y'all excited about prescribing continuous glucose monitors?
You have another question. So, it's meant to be used for long-term products, but when do you say stop? Or
Generally, we don't want to stop because the studies have seen like the control, actually like the A1C reversal. So ideally, as long as they can keep paying it and their insurance is covering it, that we keep them on it. I've had patients that are like CGM or bust, like that's the only way I'm going from now on. The other limiting factor is every 3 years. So if they're on the like Freestyle Libre 2 and you're thinking, maybe they should get on one of the real-time ones. It depends on their insurance if they're able to switch it. Most of the time, like the Medicare, Medicaid, they have to wait those 3 years of one system before they can switch to another. What other questions do y'all have? All right, well, this is my information. Y'all can email me. Dr. Bazaldua and Dr. Davidson also have my contact information. I'm happy to help with anything y'all need on continuous glucose monitors.
there's a bar going on, he's able to prepare that.